So good evening, everybody. Sorry for the video quality. I'm having some challenges with my laptop today. So today, Dr. Suresh is going to speak on management of burns in the emergency department. Suresh is the head of emergency department at Yashoda Hospitals in Hyderabad. He did his MBBS from Vijayawada, and he has done both his diploma and... Give me 1 minute, please.
Somebody's echoing. Suresh, you need to. I need to.
Vidya? Yeah, you have to.
Are you able to hear me?
Vidya, you have two devices on. You put off one of them, introduce, then you can get back to the other.
Can you hear me now?
Yes.
Yeah.
Yes.
So, sorry about the technical glitch. So Suresh is the head of emergency.
If there is a difficulty, I can introduce myself.
Yeah,
with the
I think that
Dr. Shivaram, I think Dr. Arun. Yeah, can I? Yes.
Yeah.
Can I start? Yeah. Hello, hello everyone. First, I am Dr. Suresh, heading the emergency department at Yashoda Group of Hospitals at Hyderabad, in southern part of India. The Yashoda Hospital is a 2,000-bedded hospital with 100-bedded emergency units across 3 locations. I did my MBBS at Siddhartha Medical College, that is Government General Hospital at Vijayawada. Thereafter, I completed my diploma in emergency medicine as well. I completed my MKM residency at Apollo Group of Hospitals. And then thereafter, I worked as a consultant and the head of the department at Medicover Hospital, as well as later at Yashoda Hospitals. Then in between, in 2020, I was there with NHS UK for 1 year. And then I came back and heading the group for the emergency department at Yashoda Hospitals. That was my brief introduction. And today, first of all, thanks to Marvelous Medicine. It was a good initiative by Dr. Radhakrishna sir, and thank you so much to Vidya ma'am for being part of this program. That is a series of webinars which I closely follow the Marvelous Medicine group of webinars, and very thankful for the opportunity. Today, my topic is I'm going to talk about the managing an acute burns patient in the ER. I'm going to touch a few aspects, how we manage the burns patient in ER when it is come to the emergency department. Later, anyway, continuum of the care will be taken by the critical care specialists as well as the plastic surgeons in India. So how we are going to deal with, I'm going to elaborate over the next 30 minutes. And slides are visible, I think so. I should, yeah.
Yes, you can see them well.
Yes, ma'am. Yes. So today our objectives for the session are, we are going to describe the assessment and classification of burns, how we are going to classify the burns, and how we can assess and to implement the general management principles in the emergency department. As well, we need to keep in mind for the airway of the patient in burn injuries, why we need to be careful about the airway of the patients in burn injuries as well. What are the potential risks involved? How we need to assess and then immediately act, that we are going to elaborate. Of course, burns patient we see as a trauma victim. Even in the ATLS, like advanced trauma life support, if you see burns is one of the chapters, and we need to deal with the burns patient as equal to the trauma patient. How, why, and why, that also we are going to elaborate over the next slides. And estimate the extent of simulated patient burn injury. any patient has come with a burns, then we need to calculate the extent of burns based on the weight as well as the percentage of burns, and that guides you your initial resuscitation in the emergency department. That we are going to throw some light, as well appropriate management of different types of burn injuries. That also we are going to elaborate a bit, as well at last how you need to give the proper handover when you're dealing with burns patient. If you're at the secondary center, when you're shifting the patient to the tertiary care center, what is the methodology, that also we are going to elaborate. As well, to make it interesting, so just we start with the case scenario. So here we can have one case, 29-year-old young male. He jumps from the floor in a burning house. Here, one of the aspects is it's a missed mechanism of injury, sustained, symptoms and signs and symptoms, and treatment issues. Any emergency patient in the emergency department, he got a call from EMS or any fellow bystander that 29-year-old male jumped from the fire which is burning, and cloths on fire, and fire extinguisher is on, and he summoned EMS. Initial evaluation, like he was conscious, hesitated, voice normal, he complaining of pain in the abdomen and leg, and he's hearing the abnormal, and then his body was extensively burned. So this is called as an initial assessment without touching the patient. Here, as soon as you see, based on the initial information we gathered, we got to know that he has sustained severe extensive burns over the body. As well, he jumped from the burning house. That does mean that he sustained another injuries. That means he sustained trauma to his musculoskeletal system. That also we need to look into while dealing with any burns patient. That's why we need to gather the information very meticulously and accurately whenever you are receiving any burns patient. If you have a pre-arrival notification, try to gather the information as much as possible. As you know, terrorism and all those blast injuries, so you need to know date of incident, time of incident, place of incident, as well as the mechanism of injury and number of victims also, so that to guide the patient management in emergency department. How they are different, basically. So if you can see, so in patient with burn injuries, first of all, we need to stop the burning process. And you need, as we all know through the pathophysiology, there was an inflammatory response within the tissues, which leads to the energy transfer as well as the resultant edema, which they may not evident immediately, but later the edema might develop, whether from the airway, starting from the airway to the chest, as well in the lower part. Here, in a systematic approach, that is ABCDE manner, we usually treat the patient in emergency department. So we need to know about the burning process, how we need to stop. If patient is unclothed, you try to remove the, first of all, you need to have your own safety. If you are at the scene, if you are at the hospital, yes, if it's okay. Then you move the patient quickly to the resus area, then remove the burning cloth, but never try to peel off the adherent cloth. That will cause more harm to the patient. And if the type of burn we got to know, suppose the scenario, as we mentioned, he was in the burning house, that was inside. So here I can suspect parallel carbon monoxide poisoning along with the trauma he has sustained, as well if the plastic is involved inside, I might suspect the cyanide poisoning also. So you need to know all these factors while dealing with any burning victim. So if it is a dry chemical powder, yes, it can continue to burn. So if dry chemicals are present, yes, they should be brushed off immediately in the decontamination area, and you need to rinse with the copious amounts of warm saline or placing the patient in warm shower. So you need to know all these things. Assessment of the burns, yes, we categorize the burns based on the severity of the extent of the skin involved. We all know that superficial burn, so they are only epidermis is involved, and they are red and hot, tender to touch, and they might give you, they are very painful. So you need to put just to run it over a tap water, okay, and then you might get a mild discomfort. So you need to give the analgesic. As well, you can apply the topical cream, and then if you can seek medical help as and when required only. Coming to the second degree burns, epidermis and part of the dermis are involved here. Usually we see blistered, red, and they blanches with pressure. Never try to pinprick those. Okay, they are very sensitive, light to touch. You need to do it in a sterile environment. These can be treated on outpatient basis considering the amount of burns. Usually they heal over 1 to 3 weeks. These are all important, deep partial as well as the full thickness. You can see here, if we consider deep partial thickness burns, and here epidermis and most of the dermis involved, and you can see they may not blister, but they appear to be white and poorly vascularized. They're very less sensitive to touch, but these take around 3 to 4 weeks to heal. These require medical attention as well. They often require excision of the wound as well as a skin grafting. Full thickness burns, usually these are dry, leathery, and insensate, and it extensively involve into the subcutaneous tissue, also the epidermis and dermis. Usually we see in the electrical injuries or when the cloth caught on fire and skin is directly exposed to the flame. So these full thickness burns always need skin grafting. Coming to the case scenario, yeah, as we received this case, first thing always you do is stop the burning process as we mentioned, and always as an emergency physician in the emergency department, or even if you are at the secondary setup, whoever is the medical person who is attending the burns patient, always follow ABCDE approach. That is airway, breathing, circulation, visibility, and exposure. You can mix these, but excuse me, sorry. You can mix these, but parallelly, but simultaneous resuscitation should happen with the team approach. If you are having a limited resources, always try to go with the ABCD approach. Initially, try to focus on the airway and ventilation and gain an IV access. Always attach the patient to the monitor. Yes, always ABCD approach, whatever the case, whether it is a trauma or burns case, always we need to treat the burns case as a trauma case, and then we need to follow airway with C-spine protection. And then if you see like airway, yes, it is very important. As well, you need to immobilize the C-spine. Why? Because we don't know how the patient is going to be. That's why we need to categorically see the mechanism of injury and try to immobilize the C-spine. Once your secondary survey has been done, then we can just remove the cervical collar. Here, breathing has a very important component here, eschorotomy. If you have a circumferential chest burns, here eschorotomy come into play. I will not go to the circulation. Yes, I parallelly get an IV access, start the IV fluids, but I try to concentrate on eschorotomy if anything impaired with the breathing part in a case of circumferential chest burns. Circulation, visibility, exposure, as I said, we see one by one. Yes, how I can see airway is compromised. Does the patient have any difficulty in talking? Has the patient had any stridor? Has the patient has any singed nasal hair or facial hair? If you open the mouth, do you see any soot? If throat is swollen or burned, if any visible swelling is there, yes, this patient has a compromised airway, and you have to secure the airway with preferably advanced airway. Why? Because once the laryngeal edema sets in, it is more difficult to secure the definitive airway. Here, I emphasize that patient, if you have these clinical features, usually we proceed with the advanced airway placement prior itself before going to the breathing and circulation part. Yes, American Burns Life Society indications for early intubations, the signs of airway obstruction as the clinical features we mentioned, and total body surface area, if it is greater than 40 to 50, if you have extension, deep facial burn, yes, you need to proceed for the advanced airway placement. As well, there is a risk of edema, or if you already patient had a significant laryngeal edema, you need to proceed for the advanced airway placement. As well, difficulty in swallowing, signs of respiratory compromise, decreased LOC. This decreased loss of consciousness might be due to hypoxia. Here again, we need to see if the patient is agitated. Yes, I will intubate straight away rather than to wait for some time or before proceeding for the circulation factor. As said, is there any history of fall? In the scenario mentioned, the patient had a fall from the burning house. So here, always suspect the C-spine injury. Try to stabilize the C-spine with a C-collar, that is hard C-collar, the cervical collar, that is Philadelphia collar. And again, when you're opening the mouth and try to use the jaw thrust instead of the head tilt chin lift manual. Breathing, again, it's a simple approach like eye inspection, palpation, percussion. Palpation, percussion, yes, I need to limit a bit, but I can see the chest distractions here, whether it's shallow breathing or rapid breathing. I can count the rate here, and then if I see that any patient tachycardic, tachypneic with signs of airway compromise, then obviously I secure with the advanced airway, and then I will see any circumferential cyanosis as well as the we need to see circumferential chest burns. Yes, here if I had, then I might plan for the eschorotomy, okay, based on the patient condition, and always auscultate to check for any added sounds here. Circulation, as soon as you prioritize the patient as priority one, all the burns patients need to be prioritized as one, okay, greater than 10 to 20%. Yes, I always prioritize as one, move the patient to the resus area, I connect to the monitor. If possible, I will take the 12-lead ECG, especially in a case of electrical injury, and I look for the color of the skin, pallor, general clinical features I see. Here I can evaluate the depth of the burns, okay, if we have time, and then always calculate the cap refill time, and then secure 2 large IV access, that is peripheral cannula initially, and you can start the giving fluids, how we are going to do by the Parkland formula that we are going to discuss. Circulation, how it is different from the in burns. As we all know, you need to progress, we all know the progression of inflammatory response, and you need to initiate the burn resuscitation. Just immediately you can calculate by rule of 9 or Landau-Browder chart. And initially you can start with if 70 patient, like 70 kilos patient, young adult has come. We usually start with giving 1.5 liter of ringer lactate. Okay, that we calculate with the meanwhile someone can calculate the percentage of burns. So percentage of burns into your 2 mils per kilo as per the latest 10th edition of ACLS guidelines, and into weight. This we divide half, we give it over first 8 hours and remaining over 16 hours. Always we see the clinical response or we see the heart rate as well as the blood pressure as well as the urinary output to see your response for your circulatory resuscitation for the circulation part. In adults, we usually maintain 0.5 mils per kg per hour urine output. Circulation, as I mentioned, like we usually follow for the adults rule of 9. As we all know, quickly, just we usually draw quickly head 9 and then anterior and posterior trunk 18, 18. So we divide 9, 9, 9, and then chest abdomen will be 9, 9. So in that way, we usually calculate, and we always remember like each upper limb is 9. Each upper limb is 4.5%, and each lower limb is 9, 9, 9. So we can calculate totally like it will come around 36% into the lower limbs and then 9% over the upper limbs. In pediatric population, we usually call Landau-Browder charts. We quickly measure, and then the same Parkland formula will apply. But here, if it is less than 3 years, we are going to less than 4 years, we are going to take the 3 mils of fluid resuscitation instead of 2 mils. This is as per the latest updates. But ideally, we always see the urine output. If the patient is shifting from the secondary center to the tertiary care center, we always see how much the resuscitative fluid has gone at the secondary center. We usually calculate and then the Parkland formula. And then suppose if it is if it is coming as 8 liters, he has received 2 liters, then we quickly give that 6 liters over the initial 8 hours. So in that way, we are going to calculate under the next 16 hours, we are going to give the remaining fluid. Here, one exception is there for electrical injury. Here, we need to give the 4 mils of ringer lactate, okay, for the to implement the Parkland formula. Here, the urine output, we usually maintain it 1 to 1.5 mils per kg per hour. So always remember, adults 2 mils per kilo, and we maintain urine output at 0.5 mils per kilo. Children, that is less than 30 kilos, 3 mils per kilo, and then we into percentage of total body surface area. For electrical injury, it's 4 mils. Disability, yes, I secured the airway. Breathing, okay, advanced airway placement has been placed and then connected to mechanical ventilator. and then circulation. I secured 2 large bore IV cannula. I started the fluids. Now I come to the disability part. Now I need to take the simply is there any history of LVC? If patient is not intubated, here I again go to the detailed neurological examination. I quickly calculate DCS, get the BM, that is your bedside glucose level, and always check the pupils. So later, again, exposure. Here again, I will examine from head to toe and carefully evaluate all the injuries. If I calculate Parkland family at the circulation part, it's okay. Otherwise, I will expose anterior and posterior aspects. I quickly and correctly calculate the percentage of burn, and then I proceed with my resuscitation. And always check for the presence of other injuries, as we always treat the burns victim as trauma victims. Yes, secondary assessment. I completed my primary assessment. Quickly, I took care of my ABC part. Now here a secondary assessment. I quickly get the edging, whether it is ultrasound or your X-rays, chest and pelvis. If the patient had any deformity over upper limb or lower limb, your chest compression test and pelvic compression test, all these things I will do here. And here I can just talk to the family. I will give them a space to discuss about my management over the next 2 to 3 days, and I will take the detailed history, what exactly happened. Why? Because if it is a burns, again, medical legal aspects involved here. So I need to take a detailed history. Is there any concomitant victims are there? Where are they? That also I'm going to see. And we quickly while getting the blood itself, we quickly see the venous blood gas. Here I can measure the lactate. I could see the CO2 retention. I could see the any hypoxia. If the patient is in acidosis, I can see, and all these things I can do. I can just manage the case. Now, as I said, like completely exposed, but here edgings again, placing an NG tube and then Foley's cath. After that, in a Foley's cath, if you see the minimal dark urine, what does it signify? It is very important in burns cases. You could see majority of those patients who are getting shifted from secondary care center to the tertiary care center. We often see these urine bags are having this dark colored urine. What does it signify? This signifies the myoglobinuria. Here again, we need to be careful about the resuscitation, giving circulation part. I mean, we need to calculate appropriate to the fluid deficit, and we need to give the fluids appropriately to maintain the urine output at 0.5 mils per kg per hour in case of adults. This would maintain the end organ perfusion, okay, in the aspect of ongoing intravascular fluid loss as well. As of paramount importance, always monitoring the urine output over the period of time is a good way to measure end organ perfusion and adequacy of it will measure the adequacy of our burn resuscitation. So this was totally, it was dealt with this patient. Coming to case scenario 2, look at this case. So here, what are all the injuries or other factors we need to worry about? We need to worry about. You could see here from top to bottom. Yes, he had a significant facial injury, his neck part involved. So ideally, this patient has to be secured with the advanced airway placement. And then you could see in the breathing part, he had a severe circumferential chest bump here. And as well, he jumped from the first story of burning house. Apart from the compromised A, B, C, again, he might have sustained other injuries, other traumatic injuries, which we need to look into. Again, here the ischorotomy come into place. Quickly, if it is the circumferential chest burns, quickly do the ischorotomy before proceeding to C, as well as other aspects of the patient management. As we all know, that circumferential burn injury, whether it is in the chest or upper limbs or lower limbs, this burn edema, built to a point that it compromises the tissue perfusion, wherein the patient developed the compartment syndrome and rhabdomyolysis as well. So that's why we need to perform the ischorotomy here immediately. That is to maintain the perfusion of the distal limbs or any extremities. This type of burn, why we need to worry about? As we mentioned, every time burn is not secondary to the flames or something. So you can see the shiny lower limb here. This is a chemical burn. So usually chemical burns are due to acid, alkali, or organic compounds, which acid generally drain cleaners, usually we see in the household. Alkali or rust removers as well as the swimming pool cleaners. Organic compounds are general phenols as well as petroleum cleaners. Initial management, as we all know, like alkali produce more tissue damage than acids. Why? Because they penetrate much deeper. Dry substances always has to be brushed properly, and you need to take the patient to the decontamination area when you are dealing with any blast injuries as well any chemical burns. If it is a wet substances, yes, we need to irrigate with copious amounts of water. Usually our decontamination areas in any tertiary care setup had a flush system, which has a shower. So usually we place, usually we place on a trolley and then we immediately flush with copious amount of water using a shower, handheld shower. Always decontaminate the patient, medial to lateral, anterior to posterior, and always remember you need to wear a proper PPE to protect yourself while dealing with any blast injuries or any fume, any chemical flames, all those things. So you need to take care of yourself before dealing with any chemical burn victim. Usually the hydrofluoric acid burns are pretty much common. For this, there is an antidote here, which was mentioned like we can put the area, that is immense burn area, for 2 hours in 0.2% tetrazine benzalkonium chloride or iced aqueous benzalkonium chloride. Always apply towel soaked with Zephyrin and then change every 2 minutes. For pain is of paramount importance. Any burns victim, you usually prefer opioids over NSAIDs. NSAIDs, we don't know the kidney status. Patient might be leading to AKI, acute kidney injury, that could be prerenal due to the myoglobinuria or severe fluid deficit. Always try to give the opioids to give the pain relief in case of any burns victim. If in the case of hydrofluoric acid burns, the complications are hypocalcemia and hyperkalemia. These we need to look into as well. Always any burns victim, you usually do the cardiac monitoring over next 24 to 48 hours. Especially hydrofluoric exposure can cause a prolonged QT intervals and ventricular dysarrhythmias. This we need to look into. And this antidote is calcium gluconate, that also you can apply of 2.5% of the burn area. As well, you can infiltrate subcutaneously as well as IV regional also you can give. You can see another case here. So typically we see it's an electrical injury which has a deep thickness burn, and the hand is like this could be the entry wound. The patient might have caught hold of the high electric wire. So what is my management here? Related to any electrical injury while dealing with the trauma. So you need to, any electrical injury, they throw the victim out of the scene. So he might had any posterior dislocation that you need to see of the shoulder. As well, we need to see again head to toe examination. You need to see the other injuries. Usually, we put onto the cardiac monitoring for this patient. Why? Because this high voltage could pass from the entry to exit wound. It could be anywhere inside in the body. So they might travel across it and it could damage the muscles extensively. These patients could line into the myoglobinuria and later rhabdomyolysis as well as the cardiac dysarrhythmias. Always put a cardiologist in loop in a case of electrical injuries. This is another pediatric age group. These also we usually see. This I think hot liquids just poured over the face, and as well as you can see the trickling down of the burns. So usually they too tend to have the physiological reserve, but they tend to deteriorate rapidly. Pediatric age group, you always need to be careful, and there are modifications while dealing with the pediatric airway as well as the circulation part. The calculation is by London Broader charts only, but while dealing with the pediatric age group, always you need to be careful about your wet flags. We usually calculate wet flags before if we have a pre-arrival notification, before the pediatrician come or pediatric intensivist come. As well, you need to be thorough with the pediatric airway modification as well as the circulation part. So documentation, it's very important. Always any burn case, even if it's a high profile case anyway, it has to have the proper medical legal documentation that involves the patient history, injury sustained, as well as the IV fluids given, and where the patient had been treated initially before shifting to your place. And in the medical record, in your initial trauma sheet, just you can mention the percentage of burns, what are the analgesics you have given, and vitals, what are the vital parameters, which were at the time of initial resuscitation. We usually measure over every 15 minutes if it is a more than 30% burn. And what is your response to your initial resuscitation related to ABC you need to put in the in the discharge notes, or when you're transferring the victim to critical care unit, always measure in a S-bar format. That will save us in the documentation purpose, as well as it will reflect on the patient safety. Own description, again, whether it is a first degree, second degree, or third degree, always the burns patient has a mixed pattern. So in some parts, it usually be superficial partial thickness, that is partial thickness. Some places they might have a deep thickness burn. So you need to, if you have the chart already, just you can highlight those areas which had second degree and third degree burns. Always dressing. Yes. Do we have to apply dressing? Yes. Once you take care of the ABC part, always cover the wound areas with a proper clean linen, so that I can ask the plastic surgeon to come over and have a deep look, and then he can manage appropriately. Okay, always what all that, if you are at the secondary center, a copy of flow sheets should be transferred with the patient when you are shifting the patient to any tertiary care center. So what are the criteria for transfer? Excuse me. So if the patient had more than 10% of total body surface area of partial thickness burns, burns over specialized areas, electrical burns, chemical burns, any inhalational injury, and burns with concomitant trauma, social issues. Suppose in the Western countries, in UK or US, we don't have a social support at home. Always they need to be institutionalized, and they need to be shifted to the burn center. So in conclusion, while dealing with any burns patient, we always look into the, as if the patient might have sustained trauma, always in a ABCD approach. We usually do the resuscitation, and with paramount importance on airway and breathing and circulation. Analgesics, again, always opioids. And temperature, here again, we need to prevent the hypothermia as well. That also you need to be have a look into, and you need to cover the entire area with the clean linen. Skin integrity, again, you need to be very careful. And tetanus, yes, as per the Green Book, yes, tetanus immunoglobulins are required more than 10%. We always give the tetanus immunoglobulin to any burn victim. Antibiotics, yes, usually some say like initial antibiotics are not required. I think we can just hold the antibiotic for a while, and we can take a call based on the extent of injury as well as the duration of the injury. Okay, thank you.
Thank you, Dr. Suresh, for finishing on time.
Yes.
Dr. Shivaram was already logged in from the beginning. He's a consultant plastic surgeon at Apollo Hospitals and Sundaram Medical Foundation, Chennai. He did his MBBS from Madras Medical College, and after doing his DNB in surgery, he went on to Edinburgh and completed his FRCS, and then had specialized training in plastic surgery in the UK and was awarded FRCS. He has delivered several lectures in national and international conferences, published papers, and authored chapters in textbooks. He's interested in philosophy, evolutionary biology, and Indian classical music, and lately in old temples. Dr. Shivaram, your comments, please.
Thanks, Dr. Vidya.
Suresh, if you could just stop sharing your screen.
Yes, ma'am.
Yeah, we can. Thanks, Suresh. That was a difficult topic, and you did a concise job of it. Before I ask you further questions, 2 points that we need emphasis on, so that audience are very clear. Now, he gave you the formula. You must remember that the formula itself is not that important as the principle behind it. The idea is there is a vast output of fluid into the third compartment, lost in the immediate aftermath of a burn over the 24 hours, and that's what we are trying to replace. Bulk of it to be replaced in the first 1/3 of the time, and the remaining can be done a bit slower. In other words, you cannot rush in a huge amount of fluid. That is one. Second point is the time when you calculate using Dr. Suresh's formula, make sure that you are calculating it from the time of the burn and not from the time you see the patient. It is quite possible the patient could have gone to 2 or 3 hospitals and come to you about 4 or 5 hours later. So they're already behind in the fluids. So your calculations start from the time of the burn and not from the time you see the patient. All right. So let me just ask the first question, Dr. Suresh. As we all know, I mean, you know more than anybody else, as emergency room physicians, the most important thing is a patient who comes in and they're screaming in pain. So the single most important thing in an emergency situation is you have to stop the pain, whatever you do pathophysiologically. Yes. What is your choice? What is your first method and drug of choice for the pain?
So usually, so always we insist on, as soon as we are doing the primary service. So we always, if it is a wound is exposed, we need to take care of the wound. The covering the wounds with the clean linen itself will reduce the pain. As well, we quickly secure the IV access. We usually give the opioids here. Fentanyl we give usually here.
Yeah, can you elaborate a little bit? The reason why I ask is a lot of people, you say like the boy you showed, he's got about 60 to 80% burn. We don't know, we haven't seen the back. So it might be very difficult to access the airway. And so they might be tempted to give a strong sort of intramuscular. Now, this is a wrong thing to do because the patients are hypotensive and they're shrunk. And then when you start resuscitating, the volume opens up and suddenly they have a whole influx of opioids into the system and they go into respiratory depression. So it's important to give it an IV intravenous. Second, it's important to give it a small boluses. If you're going to give fentanyl or morphine or pethidine or whatever, dilute it into say 20 or 30 cc and give small aliquots at a time so that you don't overdose the patient. You can keep on giving small shots. That is what I wanted to know. I thought we had another moderator. Can I just open this for the discussion? So,
Dr. Shivram, let me just bring in Dr. Arun Nandi. He's the Associate Professor, Department of Emergency Medicine at Mount Sinai. And he's also Director, Systems Utilization and Review, Mount Sinai. Nandi is an old friend, and he's not only he's an emergency physician, he's also a trained surgeon, and he has done specialized training in burns and plastic surgery as well, though right now he's practicing emergency medicine. Nandi, your comments on Suresh's talk and any questions to him?
Thank you very much for that introduction. Can you guys hear me?
Yeah.
Yes.
Yes.
So I think first thing, Suresh, you've done an amazing job in a short span of time. I think you covered all the essentials that we need to know about burn management, and very nicely done, very clear, very, very precise. A couple of things I definitely want to touch upon: the pain medication piece, and also I wanted to touch upon a few other things. So you went through, you covered them, but I just want to reiterate and reinforce those things. I think pain is extremely important. The pain is actually very pronounced when the burn is less severe, which is a fortunate thing for us. When you have a patient who's got third-degree burns and doing sclerotomies and so on and so forth, the tissue is so badly burned and the patient is usually so obtunded that you probably don't have to worry too much about pain relief. But the people who really hurt are the second-degree burns, in which the tissue or the superficial second degrees, the part, or the burns who are first degree, because your nerves are still intact, especially if it's a large surface area. So I totally agree that you should be liberal with your pain medication. I would avoid NSAIDs. Definitely use morphine or hydromorphone or fentanyl. Fentanyl is my drug of choice, and I would do exactly as our other moderators said, that we should use small amounts frequently rather than large amounts in boluses. Second point that I think you mentioned, but I would like to again emphasize, is the early establishment of good IV access. Now, with the burn patient having a lot of surface area burn, it is oftentimes very difficult to find a good access that can be secured in the arms or legs. And you might need to put a central line in pretty early. So two things happen with the central line. You have much better idea of how much fluids you're putting in directly into the system without third spacing. You also have the ability to monitor the fluids more carefully. And you also have access to being able to give pain medications in a judicious fashion. So I actually advocate putting a central line pretty early. In our ED, we use ultrasound guidance form. I think my residents and my junior attendings have never done anything blind. So their eyes and ears are now always the ultrasound. So this is a very good practice because you know exactly where you're going. So ultrasound guided early central line placement in burns that are excessive and you don't have good cutaneous access is important. I would go with that. There are a few other things that I will hold off till later, but I would open up that discussion to the panel to see what are your feelings on early central line placement.
The early central line would also help you with blood sampling, because that's going to be a big challenge to follow up on your resuscitation, whether it is for electrolytes or venous blood gas or whatever. Dr. Shivaram, what is your practice in your ED?
Somebody has to be a bit contrarian, isn't it? So I actually would not recommend early central line placement for the following reasons. Number one, if I can do a cut down, I prefer to do a cut down, say saphenous vein cut down. In exactly the kind of scenario that he painted, in that boy who fell down and then he's got this 3rd-degree burns all over. I would very happily do a cut down. And people will say, yeah, but that will thrombose. The point is that's going to thrombose anyway. A full thickness burn in the lower limbs or upper limbs is going to, the veins are going to thrombose. They're going to thrombose in 72 hours. And the first 72 hours, I want to use them. That's one reason. The second reason is we all know that central lines have to be meticulously maintained. Central lines are excellent, as you said, for blood volume monitoring, drugs, and large-scale fluid infusions are excellent. But provided, now I worked in hospitals across the globe where I've seen fantastic care of the central lines. I've also seen places where the care is very bad. And I can't say the care is excellent all over our country. In our country, I'll be very, very wary of putting a very early central line unless you can assure that there'll be a meticulous cleaning with almost like a sterile aseptic technique. There's a nurse who's actually trained to clean the central line every day and has to be changed. You cannot leave a central line in a burns patient for several days together. It has to be rotated, alternated. And if you can assure of all those things, yes. If not, I would hesitate. That would be my take.
There is a comment in the chat box about sub-anesthetic dose of ketamine for acute pain management in burns. So, Suresh, do you practice that?
We usually, ketamine, we don't practice often here, ma'am, across the southern part of India. But usually we rely on opioids only. Ketamine, yes, if there is any like respiratory failure or something, usually ketamine we extensively used in the COVID scenario. But acute pain management, if there is nothing available, yes, I think there is no harm in giving ketamine, but there is no contraindication as such. But usually we reserve opioids for burns cases. So what do you say, sir, Dr. Shivaram?
Yeah, ketamine we use when we are doing dressing changes and after grafting or even before that. It's an anesthetic.
Yes.
Just remember, ketamine is anesthesia. In fact, it is general anesthesia. What we are talking about is analgesia. So sir, in an acute situation, in an emergency room, we need a good analgesia, adequate analgesia, not anesthesia.
So there is a lot of evidence now, sir, about use of sub-anesthetic dose of ketamine for acute pain relief.
Correct.
And it has the advantage that you will, it causes much less respiratory depression. And it is about 1/5 the dose that you would be using for anesthesia. That is the dose we are using for pain management. So Nandi, do you use ketamine in US for acute pain?
Yes, we do actually. Ketamine, exactly as you said, is an intravenous analgesic and anesthetic. Depends on the dosage you're using. and it acts at the level of the NMDA receptors. So, and it also stops the cytokine cascade. So there have been some really good trials showing the effectivity of ketamine in sub-anesthetic doses for analgesia. It is non-sedating. That is another advantage. So you can actually get very good analgesia with ketamine. We are getting more and more used to ketamine in our emergency practice.
Right.
And it has both an anti-allodinic and anti-hyperalgesic properties. Those are two additional, additional kind of advantages. But there are some good studies are coming out, and it shows that it's particularly effective in acute pain settings and acute post-operative pain settings. So, once you've done your escartomy and you've done many things like that, especially in electrical burns, I tend to use ketamine quite liberally nowadays.
Shivram, I can come to the venous cut down as house surgeons. We used to fight each other to make
Yes.
it cut down, and
Yes.
that it looked technically a lot easier using a needle and all that. And any burns patient immediately you have to go into surface cut down actually at the ankle area. And actually after a while, the whole wound is not very clean or not taken care of properly. Are these cut downs done even now? Because I think a lot image guided percutaneous punctures of veins have come up. Do we still do cut down? Cut down, I think, is a very obsolete procedure.
Yes, I agree with you. It is obsolete. But, one has to be contextual. In an ideal situation, as I mentioned, if you can do a good central venous line and meticulously look after it and rotate it as per guidelines, ideal. I wouldn't do. But if you cannot, then it is less dangerous to the patient to do. I'm talking about the first, in the emergency room. I'm not talking about the later management of the patient. That's a completely different story. We are talking of the immediate management of the patient in the emergency room. No major burns patient is going to be in the emergency room for more than a few hours. He's going to be transferred to the burns unit. So in the emergency room, so this is what you're going to do. And there's no harm. You can take it out. You can take it out. Once you get a good central line in, you can take it out. And also, I think, I'm not sure what the technical thing in Suresh would know. Ketamine. Do you routinely give ketamine in our ERs, in our hospitals?
No, Suresh said they don't use, sir. Suresh said that they don't use.
Right.
But increasingly it is being used, and burn seems to be a special place for it, because we can't use NSAIDs like Suresh mentioned. And before you do a proper assessment of respiratory thing, using narcotics which may cause respiratory depression, or if the patient has fallen from a height, then we don't know about the head injury. So many things.
Right.
There seems to be. So we have Dr. Girija Sharma with us, a surgeon who has practiced in non-metro cities and handled all kinds of emergencies. Dr. Girija Sharma, would you like to say anything about acute management of burns, sir?
Dr. Sharma, can you unmute yourself? I see that they're still muted.
Yeah. Okay, we'll get back to him later. So any other aspects that you wanted to talk about, Dr. Shivram?
Yeah, one other thing that I wanted to emphasize, which Suresh mentioned, but they may or may not have caught the attention of the others. When we are talking of formulae, when we say TBSA, yes, TBSA is total body surface area, but it is a percentage of the TBSA. So ml per kg per percentage of burn of the TBSA, not just TBSA. So if you have a 50% burn in 70 kilogram, so you're talking about 40 to 50% of the total body surface area. That is one. And he also mentioned in passing about Lund and Browder charts and so on. So these are very, very useful. Every emergency room should have a book of Lund and Browder. Lund and Browder are two people who actually formulated the charts based on the fact that the old Wallace school of rule of nines and all that become very inaccurate when it comes to children, because the surface area of the head is quite different in a child as opposed to an adult. Therefore, the rule of nines, while it is very quick and very handy, it is not accurate when it comes to children. And so the London Broader chart, where somebody else can actually quickly mark out the London Broader chart, that's very self-explanatory. We don't have to go into great detail about the chart, but every ER should have one. I make sure that our ERs have one.
Each we recommend if we are drafting any clinical pathway for trauma scenarios, like my polytrauma sheet had an burns like a victim image with the both charts. So it's better in any trauma, all the trauma sheets in ED should have these charts like rule of 9 and London Broader, so that it would be easy when we are calculating the percentage of total body surface area.
Nandi, would you like to add anything else? Some other aspect of ED management of burn?
There is a very good Cochrane article, if anyone wants to look it up, in 2005. And there's also a huge meta-analysis in the Journal of Clinical Medicine in 2021 on the use of intranasal ketamine. So if anyone's interested, look them up, because we have started using this more and more instead of using it intravenously. So just an added addition. There is one thing I'd like to ask, Suresh. You've done a great job, but in terms of monitoring, we have used so many ways. You look at the urine output, not very reliable. You've looked at central venous pressures. Unless you have a central line, you can't really monitor it. We've looked at A lines, and then we've looked at ultrasound for adequacy of fluid resuscitation using the RUSH protocol. What is your preferred method of assessment of volume status in a patient during resuscitation?
So always we use, as you rightly said, we use bedside ultrasound often. We quickly screen the heart as well as IVC. So if it is collapsed, yes, then IVC, then we always assess, we mix the parameters. Like I used to see the clinical parameters, like cap refill time. And it's a mixture of all, like your heart rate, blood pressure, your IVC, and your heart contractility. If the patient is having any comorbid, it's like if it is a 60 ml, my fluid resuscitation, if it is a pediatric age group, my fluid resuscitation will slightly vary. But we always rely on RUSH protocol as well as the clinical parameters as well as the urinary output. Our setup is a tertiary care center. We used to get a lot of referrals from the other aspects of those. We get a referral from a lot of secondary centers, which are 100 kilometers away from our center. So we ideally see all these parameters. We see the urine color as well. And if it is a dark colored, high colored or something, then we calculate the formulae and all this mixture. And then we strategically do the fluid resuscitation as per the patient, not as in a general rule.
Can I just add a word here? I think what Dr. Nandi asked was an extremely relevant question, because the urine output can be, if you're just relying on urine output, it could be misleading on several counts, particularly in the pediatric age group. There's a lot of evidence which suggests that chasing urine output may not always be a good idea. While it's a reasonable guideline, the trend is important. It's not always a good idea, because it is very easy to overload. And then when the patient starts recurring, the osmotic, the translocation stops, you suddenly get all the fluid back, and then you're getting into a massive fluid overload. Now, once again, at the risk of sounding very simple, we go by periodic. Nothing beats periodic clinical examination of the patient. I keep going back to the patient and ask him to simply put out the tongue. A dry tongue tells me a lot more than a whole lot of other pressures. An axilla which is not wet tells me a lot. Even in the coldest of places, I always find the axilla wet and the tongue not dry. So these are important. While urine output is extremely important, the trend, that is hour to hour change, is far more important than any single value. Right? And the hematocrit, of course.
Yes, and I think those are really, depends on where you're working. Since I've had the opportunity to work in really good centers like Mount Sinai, where every single modality is available for you in a country like the US, where every bell and whistle is available, it is fine. But just as you said, you may be working in areas where you do not have all these, and then the clinical exam becomes extremely valuable. So I've done a lot of global health, and I work in areas in the subcontinent and also in sub-Saharan Africa, and I've noticed that people often forget the clinical exam. So I think that is really important. Having said that, I'm very surprised that the other day I was holding a conference like this for my faculty in Nepal, and I was very, very encouraged to see that they are using the ultrasound more and more. And the ultrasound has become, honestly, we used to think this was our ultrasound, and we have shown that auscultation as well as palpation has a very high rate of failure, especially in burns patients or patients where you can't have normal skin integrity. So I would really push for the ultrasound, especially in places where it can be done cheaply. There are many probes and machines now available for low cost. And just to reiterate, for the RUSH protocol, for people who are not 100% familiar, I'm not saying everybody is not, but I would just reiterate that the protocol looks at the heart and the parasternal view and the apical view, looks at the IVC for its size and filling, looks at the Morrison's pouch, the right upper quadrant, right lower quadrant view, and the bladder view. It looks at the aorta. And then, to me, the most important, it also looks at the pulmonary vasculature in the left lung zone and the right lung zone. So if you see B lines, if you see evidence of fluid overload with your lung slide, with your lung probe, it's very easy. So I actually go straight to the heart, look for contractility, then go straight to the IVC, look for its filling. And then I go to the pulmonary and look for B lines. And then I'm kind of pretty reassured between these three how far I am in my resuscitation. Suresh, what is your feeling on that?
Yes, in fact, the ultrasound, bedside ultrasound is an adjunct in primary surgery in all cases, overall presenting to ED, whether it is a trauma or any kind of shock, whether it is a hypovolemic, cardiogenic, or anything, so distributive shock, anything, bedside ultrasound has to be used as an adjunct in primary survey when you're dealing with ABCD approach, and quickly grab the ultrasound probe and then we do it, and that quickly just lineate your management plan as well in the emergency department.
I'm glad that you're saying this because I really think within you. So we always, when I was starting off, it wasn't popular, and now we always talk about the pump, the pipe, and the tank, right?
Yes.
So pumps, pipes, and tanks. So we constantly are evaluating that. Okay, I think that's it.
I have a question, Dr. Nandi. Here in India, corporate hospitals don't encourage acute burn patients. I don't know what is the reason behind it, and how is it in the US that any burn patient can come to any emergency, or there's some specific centers where they can go to and they cannot go to?
That's an excellent question. Really good question. So what happens in the US depends on whether you're in an urban area or whether you're in a rural area. In urban areas, the EMS triage occurs at the site. So if they have a burn center close by and there is no airway compromise or there's no cardiovascular compromise, they will go straight to the burn center. They know where to go. If the patient is in acute distress from either airway or from hypovolemic shock, they will go to the nearest emergency room. We will stabilize and then again transport by EMS to a burn center. So that's the urban scenario. Rural scenario, I worked actually in upstate New York, where we were the only hospital around for two districts, and there everything came to us. And very much like what it would be in rural India or any other place. Many parts of the US are like that. And EMS will bring you any and everything. And we do all the management there, stabilize the patient, and only when stable, we will then redirect them to a burn center, either by fixed wing or helicopter or land.
Dr. Sharma I see that the mic is unmuted. Dr. Vidya, you are asking Dr. Gija that Sharma, now his mic is unmuted, so they might want to say something. Dr. Gija, Dr. Sharma?
So GDS, sir, you must have dealt with enough burns, and what are the burn politics you've seen in the private practice?
I can see movement, but I can't hear him. Why?
So we are not able to hear you, sir. We are not able to hear you. DDS, sir, we can't hear you.
Vidya, can you unmute him?
No, he's unmuted,
He's
but I think
unmuted.
some problem with the
Yeah, he's
Mic.
unmuted.
Audio.
But, the problem.
Sir, we can't hear you at all, sir. Could you just quickly log out and log in back, sir? I think the on your phone the audio has not been chosen. Some issue. Okay. If does anyone else in the audience? Actually, it was Dr. Abhishankar, my friend, who's actually a pediatric endocrinologist, but he suggested that we should do a session for marvelous medicine on burns. So Ravi, did this fit the bill?
Mhm. I think he's connecting now.
Yeah, sir.
Yeah, it said connected to audio, but still, I think the same problem.
So could you just take off your headphones and speak directly, sir? I think we're not able to hear you. Just unplug the headphone, we may be able to hear you. You're muted now, sir? Yes.
Dr. Shiram, you get into the management of burns from the very beginning, or you come?
Yes. It's right at the beginning. Right at the beginning, because the assessment is very clear. The assessment is crucial. So, in general, the plastic surgeons, at least here, come right at the beginning, in the ER, at the ER level.
Is there anything active you do there?
Yeah, several things really. If you remember the thing I took for your PG is the first 5 days. The UK used to go, the whole burns teaching was, what do you do almost every single minute? We'll just assume that this is when he walks in, the next half an hour, next 1 hour, next half a day, next 3 days, next 4 days, next 5 days. So it's all structured in terms of what are your priorities in the first 1 hour, what are your priorities in the next 8 hours, what are your priorities in the next 24 hours, and so on. So Suresh has covered what we do initially, and like the lines and the fluids and the monitoring and looking to see whether he needs sclerotomies, chest sclerotomies or arm sclerotomies and so on. So, and other injuries. And once we stabilize the patient, then we make a plan. In fact, the plan is such that now most people would agree that early tangential excision and skin grafting in deep burns cuts down morbidity considerably. Unless the patient is moribund or got a whole lot of other problems, we generally tend to take the patient at about 48 hours and excise and graft the burns. It reduces a lot of burden for us later on. It also reduces the chance of infection. We all know the first 4 or 5 days, infection is not an issue. Unlike what others think, infection is not an issue in the first 4 or 5 days. So if you can get over the whole lot of problems in the first 5 days, at least even 50% of the burns we tackle, very good. So that's more or less what we do.
Dr. Shivram, Suresh mentioned that there is no need for antibiotics immediately, but there is a question in the chat box as to when would you start antibiotics?
Yeah, no, Suresh is absolutely right, and this is exactly the teaching all over the place. If you know burns is a sterile wound, I mean you burn and you don't get infected straight away. It's not like a road traffic accident. So in general, with some exceptions which I'll come to later, I'm sure Dr. Nandi will agree with me. In general, we do not start antibiotics until the patient starts exhibiting some sign of sepsis, some sign of infection, or we are taking the patient up for a major debridement and skin grafting. At that time, we start exhibiting antibiotics. Or in a child, in a pediatric child, suppose a child known history of, say, snuffles, comes with scalds. Even if the scalds is 5-6%, we know that, for example, the staphylococcal toxic shock syndrome, obviously for lack of time, Suresh hasn't covered, there are some burns which could be dangerous. A small scald in a child with the staphylococcus can rapidly lead to the death of the child by a staphylococcal toxic. I've seen young children dying within 5 hours admission to the ER of staphylococcal toxic shock syndrome. So there are some definite indications. There are some not so definite indications. And there are some areas where you definitely do not do that. Unfortunately, this is something that you have to formulate in your ER, in your hospital, in your area, and your city where you practice. And that is guided by the infectious disease, ER people, plastic surgeons, everybody together. I don't think anybody can offer a general guideline as to when and what antibiotic you give at what time. We tend to start later.
So Dr. Shivram, Dr. Vidya couldn't speak because of network issue. He's posted a very, a comment about early tangential excision. Would you like to just look at that?
Yeah, I'm reading it. I'm reading now.
Yes. Meanwhile, Ravi, what made you suggest that we should do a session on burns for marvelous medicine?
Well, we're all guilty of looking at the elephant from our own perspective, right? So my interest was in terms of dealing with the acute catabolic state after the initial stabilization and the use of things like growth hormone and anabolic steroids and nutrition with or without insulin in the TPN, etc. So that's what started my interest, and I thought that this is an interesting topic that marvelous medicine should take up. I am sure Dr. Shivram and probably Nandi would have a lot more to say about that after the initial management, but that supportive care is something that fascinates me.
So maybe we'll do a session of, once the patient is settled and, out of the ER, what next? We can do another session on what next.
Sure.
Vidya, I would like to know from the experts that what are the maneuvers or what are the technologies that cut down the percentage mortality? Because in the last 10 years, last 20 years, the survival has become better based on what? What are the advances that are taking place that patients are even higher percentage burns are living longer?
I think that's a really good point because we need a whole session for that. We have concentrated on the management of acute burns, but as an ER physician, I can tell you that's our first priority. But as a burn surgeon, when I was in Birmingham, that became the next challenge. There are three overwhelming challenges in the next 24 to 48 hours. One is, of course, sepsis that can set in very early. Two is nutrition. And three is fluid loss from the burnt skin. So that's why the topic of early tangential excision, burn cover with either allograft or artificial skins or even early skin grafting comes in. The TPN part is really important. It's a hugely catabolic state, and that has to be addressed. And of course, the other piece, as I said, is early sepsis. Sepsis is very hard to monitor in burns because every SIRS criteria is already positive. So no matter what indicator you're using for SIRS, you cannot identify sepsis. So early cultures and monitoring those. I'll let plastic surgery speak on that, on the early tangential excision, but those are the three main areas, I think.
Dr. Shivram, how is survival after burns improving in India? Are you happy with the pace at which we are?
Yeah, obviously I'm not. Obviously nobody can be happy with the pace of anything in India. But I think Dr. Nandi summarized it, that the three important areas being sepsis. Now, in direct answer to Radha's RK's question, what has improved? I think a better understanding of the pathophysiology of burns is really what has led to improved survival. We know that the importance of monitoring and the importance of dealing with the fluids in a very scientific manner. And as Dr. Nandi said, the importance of nutrition. It is amazing how you can have a burns patient languish for 4 or 5 days, and suddenly somebody says, hey, he hasn't eaten for about 4 or 5 days. Anybody looking at the calories, the guy hasn't eaten, he's been giving IV, he's a bit moribund, and somebody says, oh, let's give 5% glucose. So he's been surviving on 5% dextrose saline for 5 days, and nobody's even bothered about the nutrition. And the guy is already in a massive catabolic state, and then everybody is running behind the tail. So, under a better understanding of all this, and a fairly aggressive approach in selective cases. Now, I'm using my words carefully here. Aggressive, not in terms of adventurist, but where in selective cases, you can minimize the morbidity and mortality by getting rid of the burn wound. A burn wound is a catabolic state by itself. So, and a potential nidus for sepsis to set in. If you can get rid of that very early, and what has been the biggest problem in doing that all these years is that we didn't have a cover. If somebody's got a 40% burn, where do we get skin from? Now we have substitutes. You have skin banks. You can have, my friend runs a skin bank at Wright Hospital and a few other places. So you can tide over the crisis. Of course, those skin won't last for a long time, but it can last until the time that patient's own skin is ready or you can graft them again. So these are the kind of things that have made survival better in a lot of institutions. I wouldn't say everywhere, but in a lot of institutions. So if you manage properly, a reasonable, I would expect a 50 to 60% burn to have a reasonable chance of survival in India.
So I think the EMS or whatever are ambulances, as well as development of emergency medicine as a specialty also has probably contributed to improve survival because of the initial management, which is usually missed out.
Yeah, definitely. Yeah.
So any closing comments, Nandi?
Two other important areas I just wanted to also impress upon is the management of the airway, early management of the airway. You mentioned before that the signs of an airway compromise is soot in the nares, stridor, airway edema. And many times when you're in a flash burn injury, especially now with wartime injuries, it's been shown that you inhale hot gases in a blast, and that can completely compromise your airway, and you do not recognize that injury till very late. And by the time you recognize it, you have lost your airway. So please be very mindful of looking for airway injuries. Early airway intervention is also very good in terms of managing a burn patient. So there have been two schools of thought, intubate or not intubate. In case of the midline cases, I tend to intubate early because I find that if I have an intubated patient, I have better cardiovascular control over that person's hemodynamics than any other way. And if I have an acute lung injury and I catch it early, especially with inhalation injuries, I don't see that lung injury develop, ARDS develop for a long time. So you have two things going here. You're giving lots of fluids to this patient, and you have a capillary membrane that is damaged by hot air. So you are pouring fluids into a leaky membrane. You're going to flood the lungs in no time. Suddenly you have ARDS, and now you can't do anything. So I tend to manage my airways pretty early and aggressively, and this is one part that I'm aggressive. Two is local damage to the airway is also, early management is very important.
And Dr. Shivaram, your closing comments?
Yeah, sorry, I forgot to add one more point. Suresh, in our country, well, in any country really, in pediatric burns, particularly in pediatric scalds, we always be aware of the possibility of abuse. And that is something that we should always keep in the back of our mind, especially unusual patterns of injury. One other small thing that there are certain types of burns, generally we say pour cold water. But those who have worked in rural India, I'm sure Dr. Vidya Sharma would agree, somebody who is working with, Shunambu Kalavai, what do you call it, the lime kilns? One area where you can get burnt is somebody's gumboots giving way and a whole leg kicked in lime. Now, that is one area where you should not actually pour water. When you pour water on a lime burn, it actually can make it worse. So there are some few exceptions like that. So it is not always 100% always do this. So barring such exceptions, anybody working in ER should be aware of these exceptions. So they should not inflict a second injury. But in general, what is covered, the closing comments are, keep the charts, monitor the patient regularly, and then keep looking at trends in the clinical as well as the lab parameters as well as simple parameters before you hand over the patient.
Thank you. Thank you, Dr. Shivaram. Thank you, Suresh, for the covering so much in such short time, and it set the discussion rolling. Thanks, Nandi, for joining, though it's morning working time for you. And thank you, Dr. Shivram. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Thank you.
Okay.